So, hi guys, welcome to today's session. Today we are here to talk to you about the clinical based scenario in the gastric cancer. Okay, so that's what we are going to talk about. Okay, so yeah, let's start. Okay, so first is let's have a look at the presentation. So what we have is we have a 52-year-old male who is presenting with epigastric discomfort and dysphagia for last 6 months. So what the patient is having? Patient is having an epigastric discomfort and dysphagia for past 6 months. Okay, that's fine. There are two episodes of black tarry stool. Okay, so there is melena. Two episodes are there. 30 kind of pounds of the weight loss over the last 3 years. So there's a significant weight loss. There have been two episodes of blood in the stool, and the patient is having an epigastric discomfort and a dysphagia for like last 6 months. Okay. Now, the past medical history, the patient is hypertensive, the patient has hypercholesteremia, BPH, and open appendectomy has been done in the childhood, which is irrelevant. That's fine. Now, social history, she drinks 8 years a day. Oh my God, that's quite a lot. 30 packs a year smoking. So yes, the patient is a chronic smoker, no doubt about it. And the patient is a heavy alcohol drinker. So that is all kind of there. Probably if the heart disease and hypertension not that relevant, that's all fine. Medications, the patient is on tamsulosin, metoprolol, omeprazole, and Lipitor. So like nothing very, very significant in this. And there's no kind of drug allergy. So here we have a patient who is basically elderly, like 52-year-old. Patient is having predominantly abdominal complaints. There have been episodes of blood in the stool. There have been significant weight loss, and the patient has dysphagia. Other significant findings are patient is a heavy smoker and heavy drinker. So these are the significant things in the history which has been given to us. So based on this, what do you think? Okay, there can be, let's say, some kind of a benign condition like the peptic ulcer. Yes, that can be there. There can be esophageal cancer. There can be gastric cancer. So these are the predominant kind of differentials which you might have. So based on the age, all these particular things, epigastric or the gastric cancer are the top differentials. Yes, like the esophageal, like at the G junction, or this is one of the things. Benign conditions, it can be the esophagitis, gastritis, peptic ulcer disease, esophageal varices, because of all these things, right? I mean, the bleeding was there, there was some epigastric discomfort and all those things. In the malignant conditions, very, very rarely what exactly can be there. So yes, I mean, there can be gastric or esophageal cancers. That is our first differential. But the other rare malignancies which may be present are mild tumors and the primary gastric lymphoma and the GI stromal tumors and all those things. But predominantly, if we talk about the malignant, either it can be a esophageal cancer or it can be a gastric cancer. And in the benign things, we think of esophagitis, gastritis, gastric ulcers, or maybe esophageal varices. But there is no significant thing in the history. There's no what do you call as ascites. There's no other features of liver failure. So varices will be a bit lower down. So that's what we need to understand. Okay. Now, when we talk about the workup, so like how will you work up this particular patient? Obviously, you're going to take the history in detail, which we have done. There will be physical examination to see whether there's any abdominal lump which is palpable or not, or whether any lymph nodes are palpable along the body or something like that. Then laboratory tests and weighting, that's what you're going to do. In the endoscopy, it's essential for the diagnosis. So yes, I mean, that's very, very important. So the cornerstone of the management of this or the diagnosis of this particular patient would be endoscopy, because endoscopy will tell us whether there is any growth present or not. If at all there is any growth, you can take a biopsy from there. Endoscopy will tell you that whether there is any ulcer present or not, or any bleeding from any particular varices or vessel or something like that. So yes, endoscopy is definitely essential. Then goal, if the malignancy is suspected, if at all you have a malignancy, determine the disease extent, whether it is, first of all, whether it is a gastric cancer or an esophageal cancer, and whether it is limited to that particular organ or not. Okay, so that is what is our aim in deciding all these particular stuff, right? Now, risk stratification for post surgery. So, if at all, let's say there's a gastric cancer, whether it's a localized, whether it is a locally advanced, whether it's a low grade, high grade, all this particular stuff. So that is what comes under risk stratification. Okay, right. Now, family and the personal history of the gastric cancer. Okay. Now, in the gastric cancer, you can have some familial associations. For example, Lynch syndrome. What is a Lynch syndrome? What is Lynch? Lynch is HNPCC, hereditary non hereditary non-polyposis colon cancer. So there's Lynch 1 and Lynch 2. In the Lynch 2, there are extra intestinal malignancies, including the gastric cancer. So yes, I mean, you have to kind of have a look whether in the history there is some kind of a Lynch syndrome which runs in the family or not. Then BRCA mutations, okay, they are also associated with the gastric cancer. So out of BRCA 1 and 2, BRCA 2 are the ones which are more associated with the gastric cancer. And there is familial adenomatous polyposis. Okay, so yeah, these are the syndromes which you will keep in mind. Will they be very, very common? No, not really. But if at all somebody asks you about the genetic association of the gastric cancer, these are the things which you have to kind of think for. Okay, right. Now, physical examination are often normal unless disease is kind of advanced. So, yes, until unless it is a very lean, thin patient, or let's say there is an periumbilical metastasis or other kind of things, more or less the physical examination is going to be more or less normal. Okay, so yeah, that is what is the workup which you're going to kind of look forward to. Okay. Now, physical examination in the advanced disease, as I told you that it may occur in the advanced disease only. So in the advanced disease, what are the things which you might have? You all have read this. I mean, when you kind of read for your PG exam, you all have read all these particular associations. Okay. So what you can have is palpable periumbilical lymph node. What is that? That is what is the Sister Mary Joseph lymph. Okay. So they can be palpable abdominal mass, or let's say the kind of lymph nodes can be there. Okay. So yeah, like if at all there's a big kind of a tumor, you can palpate it as a lump. If at all the patient is very, very lean and thin, there can be hepatomegaly. If at all the hepatomegaly is there, then you suspect either the hepatic metastasis or maybe it can be because of some kind of a liver problem. Okay, so which will help you in understanding or ruling out the differentials and all those things. Ovarian metastasis, obviously, you will not be able to palpate the ovaries per se, but even if you do a simple ultrasound or something, then yes, I mean, you might have ovarian enlargement. So that can be there. Virchow's node, what is a Virchow's node? What is a virtuous node? Now, this is a very, very simple thing. I'm sure that you have read this many times during your kind of medical career. So what is a virtuous node? It is basically the enlarged left supraclavicular group of lymph nodes. Okay. So what happens is that intra-abdominal malignancies, they basically drain the lymphatics into this thoracic duct. Okay. So virtuous node is this left supraclavicular lymph node enlargement. And this is what is called as a Troisi-Ers sign. What is the name of the sign? It is called as a Troisi-Ers sign. Okay, what is a Troisi sign? Left supraclavicular lymph nodal enlargement. Okay, now there can be systematic Joseph nodule, which I just described. What is this? This is basically the para-umbilical lymph nodal enlargement. Okay, so around the umbilicus, if at all there is a lymph nodal enlargement, that is what is a Sister Mary Joseph nodule. Then there is Blummer's shelf. What is this Blummer's shelf? So let's say if at all there is a recto what you call as a rectovesical pouch. Okay. So what in the females it is a rectouterine pouch. So if at all you do a digital rectal examination, you may be able to palpate the metastatic deposits in this particular pouch. That is what is the Blummer's shelf. So these are the main things people can ask you during the Viva and all those things. So yeah, just remember all these things. Okay. Jaundice ascites, they can develop in the like advanced disease. If at all there is a peritoneal metastasis, the patients may have ascites. If at all there is a liver metastasis, occasionally the patients may develop jaundice. Okay, if at all the metastatic deposit is compressing on the bile duct, maybe intrahepatic biliary radicals or common bile duct or something like that, in that particular scenario, you might have a jaundice. Understood, right. Now, let's talk about the paraneoplastic syndrome. What on earth is this particular paraneoplastic syndrome? Paraneoplastic syndrome means, let's say if at all there is a malignancy. Okay. Now, every time, okay, so let's say if at all I have a malignancy and I have a systemic metastasis. Okay. Now, obviously, the metastasis will have certain signs and symptoms. Yes, that's what is going to be there. But let's assume that there is a patient with a malignancy and the patient is having systemic signs and symptoms, but in the absence of the metastasis. That is what is called as a paraneoplastic syndrome, because there's something which is being secreted by this particular tumor, which is basically leading to the systemic manifestations. Okay, so let's go through it one by one. In the skin conditions, there is acanthosis nigricans. Okay, so that is one of the paraneoplastic syndromes associated with this. Please remember this. Okay, again, not very common, but if at all, yeah, somebody may ask you. So, which skin condition is associated as your paraneoplastic syndrome with the gastric cancer? It is acanthosis nigricans. Okay, then there is thrombophlebitis. Okay, so obviously migratory thrombophlebitis that can happen. Then succinate erythema, dermatomyositis, pemphigoid, seborrheic keratosis, all those particular things are fine. But the important one, what you should remember is the acanthosis nigricans in this particular scenario. So gastric cancer